Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month, I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness. In this NEI podcast episode, we are taking a look back at this year in psychopharmacology. There have been some exciting developments this year, and we want to take a look back. I have here with me today our Chief Medical Officer, Dr. Andrew Cutler. Welcome, Dr. Cutler.
Hello, it's a pleasure to be here.
Dr. Cutler, what are some of the new FDA approvals for medications that occurred this year?
Well, it's been an exciting year. There's a number of interesting medications that got approval. The first one I want to talk about is called lemborexant, which the brand name is Dayvigo, Dayvigo. And this is an orexin antagonist that is approved for insomnia. So it antagonizes both orexin 1 receptor and the orexin 2 receptor. And these receptors, when they're stimulated, promote wakefulness. So obviously, if you block them, you get sleepiness, if you will. The actual approval is treatment of insomnia characterized by difficulties with sleep onset and or sleep maintenance in adults. And what's nice is not only did two different studies show efficacy, but it was not associated with rebound insomnia or withdrawal effects following discontinuation, or with problems with next day fatigue, postural instability, or memory problems. So certainly there is the possibility of issues soon after you take it, within 4 hours after taking it. But as far as next day, it looks like it's going to be fine. It was approved at 2 doses, 5 and 10 milligrams, and so we're excited to have a new treatment for insomnia.
Wow, that is exciting.
Yeah. Now, as far as schizophrenia, there was a new medication approved to treat schizophrenia in adults, and that's called lumateperone. The brand name is Caplyta. And this demonstrated significant efficacy for adults with schizophrenia with a psychotic relapse in 2 different studies. The approved dose is 42 milligrams a day. Now, what's interesting about this molecule, lumateperone, is it has very high affinity for the serotonin 5-HT2A receptor. And that affinity is so high that at therapeutic doses, you've completely saturated the postsynaptic 5-HT2A receptor. Now, this receptor actually works in concert with D2 receptor so that you augment D2 antagonism. So this drug does also have postsynaptic D2 receptor antagonism, but because of the high 5-HT2A binding, you don't have to bind as tightly or occupy as many of the postsynaptic D2 receptors. And as a matter of fact, there is a ratio here of a 60 times higher affinity for 5-HT2A versus D2. Now, you may say other atypical antipsychotics have higher affinity for 5-HT2A versus D2, and that's true, but the next highest affinity is only 12 times higher affinity. That's risperidone, and this is at 60 times higher affinity. Now, there's also another property that's interesting. As I mentioned, it's a postsynaptic D2 receptor antagonist, but presynaptically, it is a D2 receptor partial agonist, so partly stimulating the presynaptic D2 receptor, which is an autoreceptor, a regulatory receptor. By stimulating it, you kind of put the brake on the release of dopamine, so you're not releasing as much dopamine as if you would if it was an antagonist, both pre- and postsynaptically. So again, you don't have to occupy as many of the postsynaptic D2 receptors. You're not trying to overcome that release. And as a matter of fact, lumateperone occupies only about 40% of those postsynaptic D2 receptors. Most effective antipsychotics have to occupy 60 to 80%. So 40% occupancy is actually similar to clozapine. There's another interesting property it has. It's also a serotonin reuptake inhibitor. It binds to the presynaptic SERT, serotonin transporter, and blocks the reuptake. Now, there's also some data that was released this year that there's now 2 positive studies. The data has been released recently that show lumateperone is also effective for bipolar depression. So in the coming year or so, we may get another approval for lumateperone for the treatment of bipolar depression.
Wow.
Now, what's also very important, not only does it have antipsychotic efficacy, but these properties that I mentioned, the relatively low occupancy of D2, postsynaptically, the high 5-HT2A, and also the fact that it has virtually no affinity for H1 histamine or muscarinic cholinergic receptors, means that it has a very favorable safety profile. As a matter of fact, in clinical trials, the levels of certain parameters were the same as placebo, and that included EPS, Parkinsonism, akathisia, prolactin elevation, weight gain, and metabolic disturbance, including glucose and lipids. So this medication seems to have a very favorable safety profile and tolerability profile as well.
That sounds so exciting. That's great news.
It is a step forward. Now, it's not necessarily a brand new mechanism. There are some other interesting medications being developed as antipsychotics with novel mechanisms, and maybe we can talk about those another time. One other medication I want to talk about, and that is our friend psilocybin, which is a psychedelic, obviously, that has high affinity for 5-HT2A receptors, but it's acting as an agonist at those receptors. And the FDA granted breakthrough therapy designation for the treatment of major depressive disorder to a company called USONA Institute, USONA. And this is a nonprofit medical research institute that focuses on ways to treat depression. And this treatment is given in combination with psychotherapy, and there's a clinical trial that's underway, a phase 2 study that USONA Institute is sponsoring. It's including about 80 patients with major depressive disorder at 7 sites across the U.S., and we expect that the study should be completed with results by early 2021, and that would be very exciting. We know that a number of psychedelics are being studied for major depression and also post-traumatic stress disorder, and it would be really an interesting breakthrough to have one of those approved.
Mm-hmm. Mm-hmm. What about FDA approvals for devices and therapeutic approaches?
Well, this is also an exciting area. We're doing what I call going beyond the pill, which means that we're looking at treatments that are not necessarily medications. We're looking at things like digital therapeutics. And one such treatment that I want to mention that was cleared this year by the FDA in June is called Endeavor RX. Endeavor RX. And that's from a company called Achille Interactive. And this is a digital video game, if you will, a therapeutic video game that's approved to treat ADHD. And the way this works is kids play this game, and the game adapts and gets a little harder. And what it's doing is training the brain's attention circuits, much like if you're working out, you train your muscles and they get bigger and stronger and you can do more and they function better. The idea here is that you're training the brain, particularly the attentional circuits. And so it's approved to be used to treat attentional deficits in patients with attention deficit hyperactivity disorder. Now, it's not approved to treat all of the symptoms of ADHD, but especially for attentional. And it can be used either by itself or more commonly, I think it'll be used in combination with medications. Now, there is another device that got an interesting approval here. The FDA granted breakthrough device designation for a TMS, transcranial magnetic stimulation device, to treat bipolar depression. And this is for Neurostar's advanced therapy device. And this would be to treat bipolar depression, either bipolar 1 or bipolar 2 depression. Now, we know that TMS is approved to treat unipolar MDD or major depressive disorder, but certainly this would be very exciting because we need new treatments for bipolar depression.
Right. Wow.
Now, this is not a therapeutic, this is a diagnostic that I want to mention that the FDA approved. And this is the first radio tracer or diagnostic imaging technique to look at tau pathology in patients being evaluated for Alzheimer's disease. So the FDA approved, and I hope I say this right, fluortaucipir F18 injection. The brand name will be Tauvid, T-A-U-V-I-D, from Avid Radiopharmaceuticals. And this is a diagnostic agent for adult patients with cognitive impairment who are being evaluated for Alzheimer's disease. And the way it works is this radio tracer is injected into a vein, and then you do a PET scan, and this then binds to the tau neurofibrillary tangles. So you estimate the density and distribution of aggregated tau neurofibrillary tangles in the brain. And this approval was based on 2 different clinical trials. And I think this is extremely exciting to have something to help aid in the diagnosis of Alzheimer's disease. We need more biomarkers in our field.
Mm-hmm. Absolutely.
Now, there are two other medications that I want to mention that could have been approved this year, but unfortunately were not. These are two medications that had what's called a PDUFA date, and that stands for the Prescription Drug Users Fee Act. And the PDUFA date is the day on which the FDA rules whether your drug is approved or not. And unfortunately, and this was in the past 2 weeks, these drugs had PDUFA dates, but unfortunately, both of them received what's called a complete response letter, which is a failure to approve the drug. Now, a complete response letter can be issued for a number of reasons. It could be because of the FDA's concerns about either the efficacy or the safety of the medication. Fortunately, that was not the case with either one of the two medicines I'm going to mention here in a minute. Or it can be for manufacturing issues or other administrative kinds of issues, almost like paperwork issues. Turns out that the latter was the issue here with these two drugs. The first one, which had a PDUFA date 2 weeks ago, is called SPN 812, or Viloxazine extended release, from a company called Supernus. And they got a complete response letter because of a laboratory issue, not because of concerns about efficacy or safety. And this was a drug that was studied for ADHD in children and adolescents and delivered very positive, encouraging data with good safety and tolerability. But they had moved their lab recently, and apparently there was some glitch in the paperwork. So they are fixing the paperwork, and I'm told that the drug is on track to be approved within the next couple of months. Now, the second one is a drug called ALKS, ALKS 3831 from Alkermes. And this is a combination of olanzapine, our good friend olanzapine, and samidorphan. And samidorphan is a mu-opioid receptor antagonist. And the thinking here is by adding this to olanzapine, you decrease the drive to eat and to gain weight, and you blunt the weight gain that's seen with olanzapine. And so they have generated data in patients with schizophrenia that shows that the ALKS 3831 compared to olanzapine had significantly less weight gain and blunted the weight gain, unlike olanzapine alone, in which you can continue to see continuous weight gain over time and really massive weight gain in some patients. The approval was sought for both schizophrenia and bipolar disorder based on the original approvals of olanzapine. But unfortunately, they received a complete response letter for a manufacturing issue with a pre-production batch that was actually not the batch, the version that's going to be manufactured. And they fixed the issue, but there was a paperwork issue that unfortunately they're going to have to submit some paperwork. And again, they seem to be on track to get approved within the next couple of months. So that would be a nice development too.
Yeah. Wow. Wow. Some more to look forward to. Could you share some of the important warnings or updates that the FDA made to pre-existing labels this year?
Yes, and this happens every year that the FDA updates the prescribing information or the drug labels. The first one I want to talk about is the FDA now warning of serious complications following clozapine-induced constipation, including ileus and, sadly, including cases of death. So on January 28th of 2020, the FDA strengthened an existing warning about constipation, and that can progress to serious bowel complications. This was prompted when the FDA reviewed cases from 2006 to 2016 and found 10 cases of constipation that progressed to serious bowel problems resulting in hospitalization, surgery, or death. So this is something very important to be aware of, certainly.
Wow.
Now, the FDA also required labeling changes for opioid pain medications, opioid use disorder medications, including naloxone. So there are now new warnings, and now the caregivers have to provide information specifically on the fact that these medications are dangerous and at risk for causing addiction and overdosage. What the FDA is recommending, too, is to discuss the availability of naloxone and even to prescribe naloxone to patients and caregivers when beginning or renewing treatment, and specifically when prescribing opioid pain medicines, healthcare professionals should consider prescribing naloxone to patients who are at risk of opioid overdose. This also includes patients who are taking benzodiazepines or other medicines that depress the central nervous system, those who have a history of opioid use disorder, those who've had a prior opioid overdose, and those who have household members at risk for accidental ingestion or opioid overdose, including children.
Right, right.
They should also consider prescribing naloxone when prescribing medicines to treat opioid use disorder like buprenorphine, methadone, or naltrexone. And the FDA requires these recommendations be added to the prescribing information for opioid pain medicines and medicines to treat opioid use disorder. And we know that naloxone, which can be delivered a number of different ways, including now an intranasal device where you don't require any healthcare training, it can also be given an intramuscular or intravenous injection, but that has to be done by a healthcare professional. And naloxone can counter the effects of overdose within minutes. And again, this can be done by people with or without medical training. So this is a very important warning, of course, as well.
Right, right.
The FDA also required stronger warnings for benzodiazepines, and this including information on the risks of abuse, misuse, addiction, physical dependence, and withdrawal reactions. We know that benzodiazepines are widely prescribed, and we now have to have labels that spell out these risks. The FDA is also requiring changes to the prescribing information and to existing medication guides.
Wow. Yeah. It's important, really important.
Important safety issues.
Mm-hmm. Mm-hmm. So we know that the COVID-19 pandemic has had a significant impact on mental health around the world this past year. Can you share some findings with us on the effects of COVID-19 on mood disorders from the CLIMB study that was conducted earlier this year?
Well, yes, this is a very important study that I've actually quoted a lot lately. The CLIMB study stands for COVID-19 and Life Stressors Impact on Mental Health and Well-Being. An acronym here is CLIMB. This was a study that was looking at individuals from March 31st to April 13th of 2020. And a lot of information was collected, and databases were compared to databases from before the COVID-19 epidemic. The comparison database was the 2017-2018 National Health and Nutrition Examination Survey, or NHANES, N-H-A-N-E-S. It's a mouthful. This is an annual study conducted by the United States government. And basically what was found was a tripling of depression symptoms during COVID-19 compared to pre-COVID-19. And this study was published in the Journal of the American Medical Association, a very prestigious journal, in early September of 2020. And the first author is Ettman, E-T-T-M-A-N. Highly recommend this study. Now, the actual numbers are that before COVID-19, depression symptoms were reported by 8.5% of adults, while during the time period measured early in the COVID-19 epidemic, 27.8% reported depression symptoms. Now, this is really incredible, a tripling. And again, the sample here was early in the COVID-19 epidemic. It's certainly possible this has gotten even worse.
Right.
Because we know, if you think about what's going on with COVID-19, there's significant stressors that put people at risk for depression, especially those who have a history of major depression, or even those who've not had depression before. And those risk factors can include things like financial stress, which many people are suffering with, job loss, relationship stress and relationship difficulties, the isolation caused from social isolation and quarantine. So this is a very major finding that all healthcare clinicians should be aware of, I think, and really screen for depression symptoms and look for either full-blown major depressive episodes or recurrence in patients who have major depressive disorder, or new depressive episodes in people who hadn't previously had depression.
Mm-hmm. Sort of related to that question is, what have we learned about suicide this past year?
Well, suicide, again, is a major issue and concern, especially during times of stress, such as the COVID-19 pandemic. Mm-hmm. Even before the COVID-19 pandemic, we had a major issue with suicide, with approximately 800,000 people dying by suicide every year.
Right.
So not only has COVID-19 caused deaths from the virus itself for medical reasons, but we also expect that the number of suicides will be increasing. And there are studies underway now looking at that. Like some of the factors I mentioned that put people at risk for depression, there are a number of factors that put people at risk for suicide, and those include, again, the financial stress that a lot of people are facing due to job loss. Also, people have lost their insurance in some cases, so now I'm worried about how am I going to get health care during a pandemic. The isolation, the physical distancing, the being in quarantine, and this can lead to loss of social supports. It can lead to a disruption in people's coping mechanisms, including routines that they may have had, increase in substance use, increase in relationship stress, including abuse and domestic violence from being on top of each other more.
Right.
Also, barriers to mental health care, not only losing insurance, but also it's just harder to access mental health care in a time like this, where you may not be able to see your clinician in person.
Mm-hmm.
So what is recommended here are various suicide prevention measures such as telemedicine, increasing mental health and suicide awareness, and interestingly, a recommendation that's been made is to decrease social media exposure because of the hysteria and stress. And frankly, there's a lot of misinformation out there.
Yes. I'm so glad you said that. Yes, very true. What can you share with us about some beneficial findings on lifestyle choices and mood disorders? There was some research that came out on this earlier this year.
Right. Now, we've known for a long time, of course, that various lifestyle changes and interventions can be very beneficial for mental health. A good example is exercise, which has been shown to have antidepressant effects, to help people with ADHD, even to help people with schizophrenia. But a specific recent meta-analysis looked at physically active yoga, so a form of exercise. This is not just passive yoga, but physically active yoga. And it looked at whether this yoga was superior to a waitlist control or treatment as usual and attention control in alleviating depressive symptoms in individuals diagnosed with a mental disorder, not specifically just depression. And this was conducted up to May of 2019 and published earlier this year. And it looked at 19 different studies with over 1,000 participants, and 13 studies were actually included in the meta-analysis. And what was interesting was yoga demonstrated greater reductions in depressive symptoms than the other interventions, with a very significant difference. And greater reductions in depressive symptoms were also associated with higher frequency of yoga sessions per week. And the results suggest that yoga is an effective way to manage depressive symptoms in a variety of mental disorders.
That's definitely good information. Now, what could you share with us about some exciting findings from a study called the STARTS study, STARTS, that examined the effects of transcranial direct current stimulation, or TDCS, on schizophrenia?
This is also a very exciting study. And here again, we're talking about digital therapies, digital interventions, if you will, or in this case, this is an electronic stimulation. We're all familiar with transcranial magnetic stimulation, but this is not that. This is transcranial direct current stimulation. And what was done here was specifically looking at the negative symptoms in patients with schizophrenia. So patients underwent 10 sessions of this transcranial direct current stimulation, or a sham, twice a day for 5 days. And the device was positioned over the left prefrontal cortex and the left temporoparietal junction. And the outcome measure was the PANSS negative symptom subscale. And it turns out that patients who received the active treatment showed significantly greater improvement in the PANSS negative score compared with those in the sham procedure. And here's an amazing finding. The number needed to treat for this therapy was a very low 3.18. And number needed to treat, lower numbers are more effective. And this is an incredibly effective number needed to treat. So this is a treatment that really needs to be considered, I think, in the management of patients with schizophrenia, especially those who have prominent negative symptoms.
Yeah, wow. That is pretty exciting. So speaking of schizophrenia, what is novel or in development this year for medications used to treat schizophrenia? I know you touched a little bit on this earlier.
I did, and this is one of the most exciting areas of psychopharmacology right now because we're moving beyond medications that antagonize the D2 receptor. So I did mention that a medication called lumateperone was approved earlier this year to treat schizophrenia, and that does antagonize D2 receptors, but it has some other novel actions. I did also mention ALKS 3831, which is the combination of olanzapine and samidorphan that should get approved within a couple of months. But now we've got a couple of medications in particular in development that don't touch dopamine receptors at all, and yet they've been shown to be effective antipsychotics. The first one I want to talk about is called CEP 36856, which we actually abbreviate to CEP 856. And this is a medication that is what we call a TAR1 agonist. TAR stands for Trace Amine Associated Receptor, TAAR, number 1. And this drug stimulates TAR1 receptors, and it's also a full agonist at 5-HT1A receptors. And this drug has been shown in a 4-week study, 4 weeks of treatment versus placebo, to be significantly better than placebo at decreasing psychotic symptoms measured by the total PANSS score, and also sub-analyses showed efficacy on negative symptoms and on certain measures of cognition. And so this is very exciting news to have a medication like this. And also the tolerability, which is really surprising, is it does not seem to have any of the usual safety concerns that we associate with our antipsychotic medications. It did not have any movement disorders such as EPS, Parkinsonism, akathisia, didn't cause weight gain or metabolic disturbances, didn't elevate prolactin. Now, it turns out that there was an extension of this 4-week study done, and that's what was reported recently. And this was a 6-month extension study that showed continued further improvement on the PANSS. So there's something about this medication that seems to continue to work over time. And also, the safety and tolerability was very good there as well. So obviously, we need more studies, and this was a phase 2 study. A phase 3 program is actually just getting underway now, and so we may have some results next year, and then maybe, hopefully, they would file for approval. There's also another exciting medication in development that also works by a very novel mechanism, not through the dopamine system directly, and this is a drug from a company called Karuna, and the drug is KarXT, K-A-R-X-T. Now, this is an interesting combination drug of 2 medicines. One is called xanomeline. The other is called trospium. Now, xanomeline is a muscarinic M1, M4 cholinergic receptor agonist, stimulates M1 and M4. Now, unfortunately, it works both centrally and peripherally, and there was some data several years ago that showed clear antipsychotic efficacy for schizophrenia, as well as pro-cognitive effects in patients with dementia. However, the drug was very difficult to tolerate because of the peripheral procholinergic effects, including significant nausea. So what Karuna did was they in-licensed xanomeline, and they decided to combine it with a drug called trospium. Trospium does not cross the blood-brain barrier. It is a peripheral anticholinergic agent that blocks muscarinic cholinergic receptors. So the thinking is that we block the peripheral cholinergic effects, but allow the central cholinergic effects that we want to occur. And so KarXT was studied in a phase 2 clinical trial of adults with schizophrenia and also showed very significant antipsychotic efficacy starting relatively early. And also sub-analyses showed improvements in negative symptoms and cognition as well. So we're very excited to have both of these 2 novel agents in development. Their phase 3 program is also underway. So again, by next year, we may have some really exciting results, and we may have these drugs getting filed with the FDA for approval. Now, another development in the field of schizophrenia that I do want to mention is the American Psychiatric Association, or APA, released their latest guidelines for the treatment of patients with schizophrenia. These new guidelines are the first ones to be published in over a decade, and there's been lots of advances in our understanding of schizophrenia, how to approach its treatment, and obviously in the past 10 years we've had several new medications approved. This certainly would be very important. One of the findings, one of the recommendations in there is since these were last published, we didn't have any effective treatments for tardive dyskinesia. We now have 2 effective VMAT2 inhibitors valbenazine and deutetrabenazine, and they are now recommended for the treatment of tardive dyskinesia.
Wow.
Also, another finding that's important here, having to do with schizophrenia and other conditions that we treat, is a consensus statement was recently published about the use of antipsychotic blood levels as a therapeutic guide. And our friend Jonathan Meyer is a very big proponent of therapeutic drug monitoring, and he's in the process of actually writing a book with Dr. Stahl on therapeutic drug monitoring. And this was published by the American Society of Clinical Psychopharmacology and the Therapeutic Drug Monitoring Task Force of the Association of Neuropsychopharmacology and Pharmacopsychiatry. And they focused on indications, steady state and sampling time, therapeutic reference ranges, laboratory alert levels, practical issues, levels of recommendation, interpretation, and limitations. And so we think that this is an excellent way to improve the safety and efficacy of medications, because we know that individuals metabolize drugs differently, and even therapeutic doses sometimes can be toxic to a patient or maybe subtherapeutic for a patient who's a fast metabolizer. So this is certainly a nice development as well.
What research studies are of interest on cannabis this year? What can you share with us about that?
This is obviously a very hot area. Cannabis use has escalated significantly in America. Many states, as we know, have legalized not only medical use, but recreational use. And so there were a number of interesting studies that came out this year. One of them was looking at the association between prenatal cannabis exposure and childhood outcomes. And there was a longitudinal study called the ABCD study, which stands for Adolescent Brain and Cognitive Development Study. And this was a large study with over 11,000 children between the ages of 9 to 11, along with parent caregiver from 22 sites across the U.S. And the data was collected from June of 2016 to October of 2018. Of this over 11,000 children, 655 were exposed to cannabis prenatally. And what was found was that prenatal cannabis exposure may be associated with a higher risk of psychopathology, especially during middle childhood. So lower birth weight and reduced total intracranial volume and white matter volumes were associated with exposure to cannabis, especially after the mother knew that they were pregnant. And so this is a very important finding that says that we need to counsel women to not use marijuana during pregnancy. There's very significant consequences here.
Yes.
Now, research, this is interesting finding, research in the area of the pharmacologic treatment for cannabis use disorder is scarce. There's really not a lot in the literature about how do you treat somebody who is overusing cannabis.
Mm-hmm.
And so a recent study conducted between 2014 and 2015 looked at CBD as a possible treatment. And this was a double-blind, placebo-controlled, randomized study done at University College London in the UK. This is 48 patients who met DSM-5 criteria for cannabis use disorder, and they received either 200, 400, 800 milligrams of CBD. To see what was efficacious, there was a signal for 400 and 800 milligrams, and then those were studied more rigorously. And compared with placebo, 400 milligrams and 800 milligrams both were significantly effective at decreasing the THC-COOH, that's the metabolite of marijuana, to creatinine ratio, and that's one way of measuring cannabis use, and also increased abstinence from cannabis. So the results suggest that CBD may be a safe and effective treatment for cannabis use disorder, but clearly we need more studies.
Right.
Another study that was done, researchers examined brain functional connectivity in 54 adult cannabis users and 90 controls during what's called a cannabis cue exposure task. So you expose them to things that would stimulate cannabis craving potentially, and then they underwent functional magnetic resonance imaging, or fMRI. Changes in dynamic connectivity were analyzed and compared. They were correlated with subjective craving as well. And what they found was the variability of connectivity weights between the central executive network and the nucleus accumbens was increased in users throughout the Q exposure task and was positively correlated with during scan craving for cannabis. So the results suggest that the variability of dynamic connectivity between circuitry in the brain during cannabis Q exposure between the central executive network and the nucleus accumbens may be associated with the underlying neural mechanisms of cannabis use and subjective craving. And that gives us a window into possibly an area where we might be able to intervene.
What about ADHD? Now, I know that you had touched on one of the major studies that came out this year, but could you highlight some of the other research studies from this past year and the progress that we've made with ADHD?
Sure. I did mention earlier that there is a medication being developed for ADHD called SPN-812 or Viloxazine XR that was held up a little bit a couple weeks ago and should be approved to treat ADHD in children and adolescents within a matter of months. And I also mentioned the FDA clearance of Endeavor RX, that's the therapeutic video game or digital intervention to treat attentional difficulties with ADHD. But there's also was also an interesting study looking at self-reported maternal acetaminophen use during pregnancy and the risk of ADHD or autism spectrum disorder as well. Mm-hmm. And this was very surprising. What was done here was not only sort of taking a history, but they actually measured cord plasma acetaminophen metabolites, which is evidence of fetal exposure. Mm-hmm. And the ADHD and autism spectrum groups had higher exposures of cord unchanged acetaminophen and its metabolites compared with those who had other developmental disabilities or neurotypical individuals. Wow. So this is a remarkable study too, and it has wide-ranging impact because this provides strong evidence that fetal exposure to acetaminophen is prospectively associated with a significant increased risk of childhood ADHD and autism spectrum disorders. So not only should we be counseling women to not use cannabis because of the significant risk to their child, but also we should not be using acetaminophen, mm-hmm. which is commonly used during pregnancy. Oh, yeah. Now, another study looked at the incidence of ADHD amongst African American individuals. And what this found was very surprising. It was a large meta-analysis, and it resulted in a 14.54% prevalence of ADHD among Black people. That is higher than has been reported in the general population. Also, it appears then, for some reason, that the findings of this study stand in contrast to normal statements that African American individuals are less likely to develop ADHD than the general populations. At least in the United States, it appears that they may have a higher prevalence of ADHD than the general population, but studies have also shown they are less likely to seek treatment. So clearly more studies are done. There were a number of potential confounding variables, some of which they tried to control for. But certainly that is a study that raises some interest and really raises the need for more demographic studies on ADHD and more epidemiologic studies as well. Now, another study I want to mention for ADHD, this is for adult ADHD, and this is very exciting as well. And this is another non-medication treatment. And BrainSway, which is a company that makes a transcranial magnetic stimulation device, they recently released results from a randomized controlled double-blind clinical trial looking at their proprietary H6 coil deep transcranial magnetic stimulation system, which they call DTMS, and this was to treat adults with ADHD. We know that reduced activity in the dorsolateral prefrontal cortex has been observed in patients with ADHD. So what they did was they actually put the coil on either the right or the left dorsolateral prefrontal cortex and evaluated that compared to sham treatments. And what they found was significant improvements seen in the attention memory problem subscale of the Conners Adult ADHD Rating Scale, or CARS, self-report questionnaires for both the left and the right treatment groups. However, the right was clearly greater than the left. And so the results suggest that deep transcranial magnetic stimulation using BrainSway's H6 coil applied to the right DLPFC, dorsolateral prefrontal cortex, may be an effective treatment for symptoms of ADHD, especially attention and memory in adults.
That's Really exciting. We know that substance abuse and misuse has been on the rise this year since the pandemic. What can you share with us in terms of research studies in addiction this past year?
There's two studies in particular I want to talk about. The first one has to do with alcohol, and the second one has to do with methamphetamines. We know that stress and impulsivity are prominent risk factors for the onset and maintenance of alcohol misuse. And I talked earlier when we were talking about depressive symptoms and suicide about all the different stressors that are attendant with the COVID-19 epidemic. We know also that impulsivity can moderate stress-induced consumption of alcohol and is associated with relapse in individuals who have alcohol use disorders. There was a study published by Clay and Parker who argued that isolation due to social distancing may lead to a spike in alcohol misuse, relapse, and the development of alcohol use disorder in at-risk individuals. And they argued that this is going to place an additional strain on health services during and after the pandemic, and they recommend the importance of governments issuing public health warnings about excessive alcohol consumption during isolation, hopefully to protect vulnerable populations. Now, as far as methamphetamine, we know that the use of methamphetamine has been on the rise. And as a matter of fact, there has been a dramatic increase in the use of methamphetamine. We know, for instance, that the percentage of admissions to drug treatment facilities for the use of meth increased from 15.1% of all drug-related admissions in 2008 to 23.6% in 2017. And it turns out meth-related admissions increased among both males and females across all age groups, in all races and ethnicities, and in all regions of the United States. Wow. Perhaps most surprising and alarming, actually, is that injecting meth as opposed to smoking or snorting has increased at a very significant rate, as has the concomitant use of heroin and prescription opioids. And meth is often co-injected with heroin. These data indicate not only an increased methamphetamine epidemic, but also infiltration of the opioid epidemic into other areas of substance use disorders. Now, sadly, currently there's no medication-assisted therapy available for methamphetamine use, and hopefully this study will help to identify patients at need for interventions, either methamphetamine by itself or with co-occurring opioid disorders.
So, as my final question, I just want to ask, do you have any last final news bits about psychopharmacology that you want to leave us with this year?
I do, and this is in the area of Alzheimer's disease. This is potentially a very exciting development. On July 8, 2020, Biogen completed the submission of an application for its monoclonal antibody, which is called aducanumab, to the FDA to treat Alzheimer's disease. Monoclonal antibodies that bind to amyloid beta proteins have been studied, and a number of them have failed. However, this particular one by Biogen showed positive data in a phase 3 study called the eMERGE study, where there was 1,638 patients, and efficacy was demonstrated with the higher dose arm of the study. Now, the second study called ENGAGE, which also had over 1,600 patients, did not meet the primary endpoint, but Biogen believes that a subset of data from ENGAGE are supportive. And so the FDA was given 60 days to decide whether to accept this for review, and the FDA has accepted this for review. Now, Biogen also asked for priority review. Priority review would cut the time of an approval decision to 6 months. So we are fully expecting that sometime very soon we might hear on potential approval of the first new medication to treat Alzheimer's disease in a long time, and it would be a biologic, again, a monoclonal antibody against amyloid beta proteins.
Wow, that's so exciting.
It is. So there's a lot of research going on, a lot of exciting new developments, and companies are investing more and more money in what we call CNS research, central nervous system. So I'm really optimistic. This is a very exciting time to be practicing psychiatry and in the mental health field as well.
Yeah, so on that positive note, we will say thank you so much, Dr. Cutler, for being on the show. And thank you for sharing such incredible information with us as we look back on This Year in Psychopharmacology.
It's a pleasure. And one more thing I do want to mention is that for more ongoing updates of what's happening in the field of psychopharmacology, NEI members can access a feature called This Month in Psychopharmacology on the NEI website.
Yes. Well, thank you so much. This episode has been brought to you by the NEI Podcast. With nearly 100 episodes, you can find us on iTunes, iHeartRadio, Libsyn, and virtually any platform that you prefer to listen to podcasts. If you've enjoyed this episode, we ask that you kindly leave a review for us. Go to any of the platforms mentioned and leave a star rating or a comment. We'd love to hear from you.